Hi guys, another video. So some of you wanted to see how everything kind of fits together. So I'm going to go through a patient that comes in through the ER and gets admitted to the hospital. Okay? Hopefully this helps. Knock knock. Hi Mr. Smith, my name is Michelle. I'm going to be your nurse today. I'm going to wash my hands. I just don't have sanitizer here. So what brings you in today? You're having some abdominal pain? Okay. When did that start? It started last night? Is the pain constant or does it come and go? It's constant. Okay. And have you ever had this pain before? What does your pain feel like? Does it radiate anywhere? Does the pain radiate to your back, down your legs? No? Okay. Where at in your abdomen does it hurt? On the left side? Okay. Well, I'm going to do an assessment now. Do you have any allergies to medicines? Okay. And on a pain scale 0 to 10, 10's the worst pain of your life, what would you be at? An 8? Okay. When was the last time you had a bowel movement? You haven't had one today and that's abnormal for you? All right. So, Mr. Smith, I'm just going to take a listen. First I'm going to listen to your abdomen, then I'll listen to your lungs, okay? First you listen to abdominal sounds in all 4 quadrants. So he's got active bowel sounds on the right, but not on the left. Okay, I'm going to listen to your heart. You can breathe normal. Okay, take a deep breath. Good job. I'm going to sit you forward. All right. Listen to your lung sounds, all 4 lobes. Take a deep breath. Again. Again. And again. All right, and now I'm just gonna take a look at your abdomen. It's not distended, I don't see any lumps, no scars, nothing like that. And now I'm gonna palpate. So you always wanna palpate on the opposite side of where it hurts first. I wanna go right lower. Does it hurt here? Any pain up here? Any pain down lower? A little bit? All right. Any pain up here? Okay, so it hurts more on the left upper. Okay. Well, since you're having some abdominal pain, we're probably gonna get some blood work on you and maybe some imaging, okay? Any other complaints today? Any nausea or vomiting? A little nauseous? Oh, okay, so you had some acid reflux, but you didn't throw up. All right, any abdominal surgeries? You have your appendix and gallbladder. Okay, so you have all of your organs in your stomach. Good, good. Okay, Mr. Smith, I'm going to go get the stuff for the blood work and the physician will be in shortly. So usually for abdominal pain in the ER, we do blood work. So I'll get my stuff. I'm just gonna role play. So I've got my IV and start kit. I've got some tubes for blood. Mr. Smith, can you verify your name and date of birth, please? Very good. Okay, so I want to start an IV on his left side here. And since we'll probably do a CAT scan, I'll probably go up high. All right. So since it's been a while, I'm going to do some vital signs here. All right. Did you take anything for the pain today? I want to do his pulse ox and blood pressure. Okay, you took some Tylenol this morning. How much Tylenol? 2 maximum strength? Okay, good. Did that help with the pain at all? Not really? Okay. So blood pressure is 125/80, pulse ox 99%, And 65 heart rate. Respirations are 16. He was afebrile when he came in, so that all looks good. Now, if his oxygen level was low and he was taking deep breaths, and he needed some oxygen, we would put on a nasal cannula. Okay, so we're gonna do the blood work. Blood work takes about an hour, and then we'll probably do some imaging. So after the blood work comes back, he probably already had an x-ray. Sometimes after an x-ray, they like to do CAT scans for more in-depth pictures. So we'll just say from the x-ray and CAT scan, it looks like he has a small bowel obstruction. So sir, you have a small bowel obstruction where your intestine is a little twisted inside, okay? So your stool is unable to come out. Sometimes it does fix itself on its own. Sometimes it could be surgical. So we hope that the obstruction releases on its own. One way to release that is with an NG tube. So it's a tube that we put down your nose, and it goes into your stomach and relieves all the contents in your stomach to help relieve the pressure on your intestines, okay? So before I do that, would you like some pain medication? Okay, so the doctors ordered 2 of morphine, so I'm gonna give that to you through the IV. I'm gonna start some fluids, and I'm gonna monitor your pulse ox, because the morphine might make you feel a little loopy, could make you feel a little tired. So it also slows down your breathing rate because you're more relaxed, so we just monitor your oxygen level. If for some reason you feel nauseous or become itchy at all, you just let me know, okay? I've got your call light here. All right, let me go get the morphine and the fluids. So before I do the NG tube, I'll just start the fluids, and then I will do the NG tube before I do the morphine, just because it might make him a little sedated. So for NG tubes, you have the stomach lumen. Every facility has different kinds. And then you always want to put air into the tube so that you can make sure it's in the right spot, okay? When you check for placement, it'll sound like a toilet flushing. You just have to hear it in order to kind of get used to it. So for NG tubes, what we do is they start with their head back, you insert, and then they put their chin to their chest and you finish the rest. Sometimes you even have water and they swallow water once their chin is to their chest, and it helps it go down easier. All right, sir, I'm gonna be honest, this is not gonna be very comfortable, but I'm gonna walk you through it, okay? So you look in their nose, look at their septum, okay, it looks like the left side's okay. So I'm gonna sit you all the way up in bed. I'm gonna have gloves on, and then you measure. So this is what an NG tube looks like. It's very flexible. Some of them are not flexible, so if you get the kinds that are a little more stiff, take it and you wrap it in your hand. That way it helps loosen it up a little bit. So for NG tubes, you measure it from the nostril to the ear, from the ear to the sternum, and down to like the xiphoid process. Okay, so then I just mark it here. You lube the tip, and then you explain the process. So sir, you're gonna put your head back, and then when I tell you, we're gonna go chin to chest, and then you're gonna drink some water. So usually I always have a partner in crime with me who helps hold the water for the patient. They are gonna gag, they are gonna cough. Slower is not better with this, okay? So the head is back, so I'm gonna start. And I don't think my dummy will work, so just so you know. So I would put it in the nose, and then I would say put your chin to your chest. He would put the chin to the chest, and I would advance it all the way to where it's measured out, okay? So then it has an opening at the end. This little piece, you don't lose it because this connects to the suction. That's how the gastric contents get out. And this is a plunger, so you're gonna put like I don't know, let's see, maybe about 40 mLs of air. You're gonna connect it. This one's a little different, sorry. So you can always have two people to do this, or you can do it on your own. You listen while you punch. So go air. Okay, it sounded like a toilet flushing. So we know we're in the right spot. Also, there's gastric contents coming out. You can always check placement with an x-ray as well. And then you tape it. You'll tape it to the nose. Okay, and then you'll tape it to their gown. And then you're gonna hook this up to suction, which of course in this room I don't have. So I would hook it up to low intermittent suction. So it comes in and out, and it just will start pulling those gastric contents. And then from here, our patient will be admitted to the hospital. And then they'll have more imaging once they're admitted to see if it's relieved itself or if it's gonna be surgical. So throughout their stay, they can be assured they'll do vitals at least every 4 hours. They'll have pain medication and probably nausea medicine, okay? So now that the NG tube is in, I would make them more comfortable. All right, I'm gonna lay you down now, okay? I'm gonna give you your morphine, and then you give the morphine over 2 minutes in the IV. If you're giving it IM, because LPNs will give it IM, you can give the 2 milligrams in either deltoid, but always make sure you're monitoring their SpO2 and pulse, just continuous, okay? Okay, so I gave you the morphine. So again, let me know if you start having shortness of breath, nausea, or any itching, okay? Your call light is here. Are you comfortable? Okay, good. I'm glad that you feel better. And then I'll come check on you in 30 minutes. And then 30 minutes later, you know, you'll probably be in before then anyways. You want to check their pulse ox, their pulse, ask about their pain, and then you're going to chart everything. So you're going to chart your first assessment. So the assessment I did was a focused assessment. Okay, so we focused on the abdomen and what was going on. And so I would chart the assessment, chart the blood work. Once it came back that it was I would chart that he went to x-ray, chart that he went to CT, chart how he's feeling. I would chart the NG tube, that the procedure was done, the size of the NG tube, check for placement, how did the patient tolerate it. You're going to chart the fluids, chart the morphine, chart reassessment, and you're going to chart that you went over the plan of care with him, that he's waiting for a room assignment upstairs, he's going to be admitted, and then once he's admitted, then you're going to give your SBAR to the next nurse. So my SBAR for the nurse, let me get closer. So my SBAR for the nurse would be, Mr. Smith is a 65-year-old male, came into the ER today complaining of left upper quadrant pain, states that it started last night, it was constant, it's about an 8 out of 10, states he hasn't had a bowel movement since yesterday, and that's abnormal for him. He's had nausea, a little bit of acid reflux. So background, he's a healthy guy, no diabetes, no high blood pressure, not on any medications, not a smoker. So then I would go over my assessment with him. He's alert and oriented, his lungs are clear, there's no pitting edema, he has left upper quadrant pain, bowel sounds were active in the right, not in the left. He was tender upon palpation. His pain was an 8 out of 10. Then I would go over my interventions. We did blood work and IV. He went to CAT scan, x-ray, and showed a small bowel obstruction. size 14 French NG tube was placed. Placement was tested by auscultation, and he was given fluids and 2 of morphine, brought his pain down to a 4. He's going to be admitted for observation and possible surgery. Recommendations are admission, pain control, medication for nausea is needed, and to repeat radiology in the morning. And that's kind of a full go around for the patient. I hope that helps, guys.